Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
And here we are at the podcast. And the sad part of this is that Kim's not here. It's not my fault. She's on a plane someplace doing something good. And Kevin said,
And we'll be on a plane or someplace next week.
is that next week? We're going to Austin? Okay. So, hi, Kathleen. Yay, Kathleen. Thank you very much. So I'm here all by myself and we get to answer a Q&A. I'll tell stories until you guys think of something you want to ask. The story this week has to do with the patients I've been seeing for the last 2 days. We just came back from Arizona and the Advanced and Symposium were amazing. Dealt a lot with long COVID. Eduardo did an amazing presentation on the dura, which is just like, if you haven't ever treated the dura in the spine and the brain. And so, for example, I had an Ehlers Danlos patient in the office on Monday, and she came in with her pain level at a 7 and the whole 9 out of 9 Baton points. I might actually publish this case because I keep harassing you guys to publish it. And nobody else has, so maybe I might get around to it. So she had all the Ehlers Danlos stuff and came in with her pain at a 7, left at a 0, which was really fun. And we did dural adhesions. She has Tarlov cysts, maybe 5 or 6 bilaterally in the thoracics, 2 on each side in the lumbars. And so we did, because she had what they called a drooping, I'm not sure that's a diagnosis, but she had a drooping cerebellum. Go figure. And so somebody decided that her cerebellum was low in the cranium because she didn't have enough spinal fluid. So their solution was to do spinal taps and do something. Anyway, when they did spinal taps, her spinal cord, because she had Ehlers Danlos, her spinal cord leaked. And so they did blood patches. And every time they did a blood patch, she got an infection and meningitis. But they decided it was viral instead of bacterial. Don't get me started. So they put her on steroids instead of antibiotics. One way and another, she survived it all. She's got a bunch of adhesions in her dura. Hi. Thank you. Isn't that a great blue color? Yeah, and click on the Q&A. We've got a bunch of those. She's back. Hi, Leaf. Yeah, it's great to be home. I get to sleep with my dog and see patients, and it's all awesome. So wait, I'll answer the questions, but you got to hear about this Ehlers Danlos patient. So she had meningitis and a bunch of Tarlov cysts, and they kept doing spinal taps and they kept doing blood patches, and she kept getting meningitis. So thanks to Eduardo, I knew how to treat the dura for adhesions. And a Tarlov cyst is where the arachnoid gets scarred to the edge of the nerve. And so it can't absorb the spinal fluid. And so the spinal fluid sort of backs up like hair on the drain. And so I did scarring on the arachnoid, had her rotate, did flex, all that. And then, so the next day she came in pain-free with, instead of 9 out of 9 Baton points, she had 1 out of 9. She could still touch the floor. So we did 124 and 77 from neck to feet. I didn't have to do 40 and 10 because she didn't have any body pain. But I did scarring in the dura and had her do a salva maneuver because she has all these head symptoms. Treated the dura at the base of her skull, and then Those patients have a high percentage of tethered cord. For whatever reason, the spinal cord gets tethered. It's around T11, 12. So I set her up, found the tender spot, because there it was, right there at L1, T12. And that's what pulled her cerebellum down, was that the dura and the spinal cord were pulling down, and that pulls the cerebellum down. But the people at OHSU that were telling her she had a droopy cerebellum, I'm not sure that's a thing, but it was an interesting day. So we did scarring in the spinal cord, scarring in the dura, with her doing trunk curving. At first, she could curve maybe 10 degrees. And then we did scarring on the cord, scarring on the dura. She got to 20, 30 degrees. And then it just got tight. And if you look at the data on tethered cord, there's this little fat pad between the dura, I think, and the spine, or the dura and the cord. So we did sclerosis in the adipose, had her flex some more, and she flexed further. She really liked that. And then, yeah, short story was she ended up with her chest on her knees and her hands on her feet, which was good. And her spine completely rounded, no head symptoms, no neck symptoms. That was all good. So, yay. Left with her pain at a 0 again. The next patient came in, and this is the part that you really need to hear. I know there's 30 of you, so and the next patient came in, and she only wanted to be seen once instead of my normal 4 times, because every time anybody touches her, she gets worse. And she said to the receptionist, "I have Ehlers Danlos." Okay. So she came in and she said, "Is it okay if I stand? Because I can't sit." Hurts when you sit? Yeah. Hurts when you stand? Yeah, a lot. Hurts when you bend forward? Oh yeah, I can't bend forward. And how are you when you roll over in bed? I can't roll over in bed either. Okay. Put your hand on the counter and lift your finger. And there's her little finger, and she lifted it about 20 degrees. I said, "Straighten your arm." No backward bending. And it comes to find out that the person who diagnosed her with Ehlers Danlos did it over the phone because she had so much pain. She's had this for 20 years. She's 58. Her symptoms started when she was 38, when she lifted weights at the gym and hurt something. Okay. I'm going to treat you, but before I treat you, I'm pretty sure you have a torn SI joint, because you can't sit, you can't stand, you can't roll over in bed. We all know that's how you diagnose an SI joint over the phone. And so she sat on the table and I did reflexes, just her knees and her feet, because she was so jacked up because her pain level was like a 7. Hyperactive patella reflexes, no neck and shoulder pain, just knee pain, bad SI joint, low back pain, and pain in her feet. And then I took the pokey wheel and I went down her hand, and was hypersensitive. 7 was hypersensitive. 8 wasn't too nice, but it wasn't awful. So 6 and 7 on the right was really bad, and on the left wasn't great. And her knees and her legs hurt because it was hyperesthetic at L5, L4, S1, S2, and she said, and my girl parts hurt. So my ischial tuberosity and my crotch hurt. They're not numb. Are they numb? No, they're not numb. They just ache a lot. That's pudendal neuritis. And then she said something that made me actually finally agree that we are going to videotape a physical exam. I have always resisted that because it's a physical exam. I have this form that is 40 years old, and you do reflexes. I did her pulse. I didn't take her blood pressure. I did her temperature, did her reflexes, didn't do her neck range of motion because she was so freaked out. And she could only lay on her stomach. Okay, if somebody has to lay on their stomach, what does that tell you about their low back? They have a disc. So they have 4, 5, S1 and S2 all lit up, hypersensitive to the little pinwheel, and she has to lay on her stomach. That means she has a disc. And she said, now she's seen doctors for 20 years for this. And she said, no one's ever done a physical exam before. They've given her steroid injections. They did an SI joint injection without Versed, which I believe is specifically mentioned in the Geneva Convention. It's exquisitely painful. Some chiropractor did craniosacral on her, but rather than do a physical exam, he actually did straight arm muscle testing without testing for the fact that C6 and 7 were hyperesthetic. He just muscle tested her with a straight arm. What does that do to her neck? It's not good for the disc. So I'm going to do it. April 9th, David Eakes is coming down. We're going to videotape how to do a basic physical exam and a basic, like focused pain management physical exam. Reflexes, range of motion, Adsons, Edens, Wrights, blah, 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 blah. And the vestibular exam and the Baton exam and the low back exam, all that stuff. It'll take about 30 minutes. It'll take us an hour and a half to film it, but the whole exam should take about 30 to 35 minutes. Anyway, we did the exam. She laid on her stomach. I treated the disc front to back. I treated the nerves from her low back to her feet. I treated from her neck to her feet because she was so centrally sensitized. She was like up in the tree. I did 40 and 10 and alternated that with 40 and 89. And then she said, oh, my hand hurts. Well, that was the one, the right hand with the icky C6 and 7. So I went from her neck to her hand and just did 40 and 396 while she's laying on her stomach. 60 minutes later, she gets up, she's smiling, she's happy. Her pain level is a 1 or a 2 for the first time in 20 years. She now knows she has a torn SI joint. She's laying on her stomach, and her husband's a lawyer. He's not a doctor. He doesn't know anything about anatomy. And I pointed at her SI joints as she's laying on the table, moved the towel up across her SI joints, and I said, you see that side? Yeah. You see this side? Yeah. Are they the same? No. What's different? Well, the one on the right is like puffy and red. Yeah, that's the one that's torn. I didn't even do a physical exam on her SI joint because she was so lit up. Anyway, so that was my thing. I came home last night. I wouldn't say I was homicidal, but I was pretty ticked. How do you see 10 to 12 doctors that prescribe Norco, which is no good for nerve pain, that prescribe various drugs, naproxen for nerve pain and a torn SI joint? Great idea. Anyway, so I was a little agitated, and you guys are getting to hear about it because I get to talk about it again, and it really ticks me off again. How do you do that with something like this that's so bad and not do a physical exam? No one touched her. And I swear to God, FSM practitioners are going to be doing physical exams. Like, really, it's easy. Massage therapists can do it. I know diagnosis is not part of your scope, but you can do it. And she has pudendal neuritis. So the pudendal nerve comes out of S2 and goes down along the vulva in males and females, goes down along the ischial tuberosities in your crotch. And it hurts like hell. And so she has that too. So I said, it's I'll fix that next time. Now you know what you have. You know what it is, you know what it's caused by, you know that it can be fixed. Your pain level's a 2. It won't last. I'm going to see you next week. You're going to get a custom care because the next time I can see you is May. And I want you out of pain between now and the next time I see you. And you will use compounded ketoprofen and lidocaine on your low back and THC, like gummies. Don't smoke it, but it's good for nerve pain, and CBD to reduce the inflammation. So that is the end of my rant. Now I will answer questions. Let's see. Okay, who's this? Welcome back. Louise, hi. Glad you like the blue color. It's fun, isn't it? I like the earrings that go with that. Pudendal nerve neuralgia, nerve inflammation, scarring, too easy for said. Well, it really is that easy. You just need to look at, you can Google it. Pudendal nerve goes from, I think it's S1 and S2. And the nerve itself, when you look at the course of it, goes along the ischial tuberosities up towards your girl parts, boy parts in the front. And to treat it, you put a washcloth on the sacrum and a washcloth in the crotch, and you run 40 and 396. Now, if the pudendal nerve is scarred, it means usually that they've done a bladder suspension that went bad, and that will scar the nerve. I can't think of anything else that scars it. It's just 40 and 396. And then once you get the pain down, it has to be part of your scope of practice. You don't have to do a vaginal insertion, but it's along the bone that is your ischial tuberosities where these nerves run. And you do scarring on the nerve, and you start at the backside of the ischial tuberosities, and you basically move your fingers along the ischial tuberosities. And when it gets ouchy, you go back to 40 and 396. And then you wait until it's quiet again. Then you go to 13 and 396, and you gradually just move it. Now, what is it scarred to? It's scarred to the fascia. So maybe you have to do 13 and 142. And sometimes it actually gets scarred to the bone because look in the anatomy thing on Google. It's scarred to the bone, so you might have to do 13 and 783. It's not a difficult to treat condition. It's simply nerve pain. And everybody say together, nerve pain is the easiest thing we treat. It's like this lady got off the table out of pain, like 2 for the first time in 20 years. Makes me a little crazy. She said, okay, layperson, I have a custom care, so excited to be here. Yay. My Ehlers Danlos patient, the one that really had Ehlers Danlos, the FSM practitioner that treated her from Colorado gave her an Inspirastar that has 70 some odd programs. The good news is it holds 99 programs. She didn't need but about 5 of them. And the one she needed was number 71. I know the Inspirastar is $500 less expensive, but you get what you pay for. And we have actually had 5 now practitioners who come and take the core. They listen to the equipment practicum when I tell them the difference between the machines. And then they email and say, will you give us the custom care mode bank? And the answer is no. No. I don't know what they have on the Inspirastar. I know that on the Mend, please do not use the vagal tone protocol. We actually got another email today. I ran the vagal tone protocol on the Mend and it made the patient worse. What happened? So I explained about that. The Mend vagal tone protocol spends 40 minutes turning the vagus down. There is no circumstance under which you ever want to turn the vagus down. The person who programs the Mend read and believed Stephen Porges, and he's got the fight, flight, or freeze part. So we've got the freeze part where the vagus makes freeze, But by the time the patient comes into your office, they're not in the freeze part. Their vagus is turned down by infection, stress, and trauma. And the freeze part happens with stress and trauma. By the time they come and see you, they're not frozen. The vagus is down and it needs to be turned up. So if you have by any chance bottom end, please do not use the vagal tone protocol because it's wrong. The one on the Inspiristar appears to be right. It doesn't run the frequencies long enough. And it turns out that this Ehlers Danlos patient has to actually mail the unit back to Colorado to get reprogrammed for what she actually needs. And with the custom care software, the new software, I could update her protocol for what she needs and email it to her. So you get what you pay for. And no, if you buy an Inspiristar or another device, we're not going to send you the custom care mode bank. You can create one based on what's in the core slides. End of that rant. It seems to be, it's a rant day. What frequencies for healing from C-sections over 10 years ago? After 10 years, you're not healing the C-section, you're getting rid of the scar tissue all over the abdomen. Can FSM help with fixing incontinence from childbirth? I'm glad you're here too, Lisa. Welcome. It's really fun. I really love you guys. The Advanced and Symposium is like a big family reunion. And 2026, just to let you know, next March, the group at the Advanced, because I have 2 days and I get through what, 80, 90, 100 slides. The group at the Advanced asked me, would I please do the whole Advanced? All of them. Like all of them. Which means writing the protocols for stroke and Parkinson's and all those tissues and conditions that I just make you figure out on your own. I have to rewrite the Advanced, and we're going to do 4 days of the Advanced next March. Put it on your calendar. I don't remember what the dates are. It's the last half of March, isn't it?
I don't remember either.
I don't either.
Thought I took a picture of it, but
Yeah, it's at the end of March. It'll be on the website as soon as Kevin puts it there.
4 half days. So.
But it's 4 half days. So I'll lecture from 9 to 12. And then in the afternoon, we'll have plenary speakers, the usual Kim, Muz, Christy, probably Becky Blodgett, because she did such an amazing job on sleep apnea and its effect on blood vessels. Probably Patrick Wood, because he's really good with the brain, and I'll talk to him and see what he can do. It was amazing. Anyway, and we'll have case reports 4 days. So it's going to be a combination of Advanced and Symposium all together, but it's going to be 4 days long. It's going to be really fun. It's like a big family reunion, and it's 26, and I'm going to be 79 next year. And we'll talk about me retiring when I'm 80-ish some other day, not today. So fixing incontinence from childbirth, here's the thing. Incontinence, what you mean is stress incontinence, where the pelvic floor muscles can't hold the urethra closed and keep you from dribbling and getting in your underwear and on your legs and whatever when your bladder's full. That's what they prescribe Kegel exercises for, to strengthen the pelvic floor muscles. And when you're pregnant, the pelvic floor muscles get stretched. So you do 124 and 77 because the pelvic floor muscles have these connective tissue attachments to the bone. And so you do Kegels to do that. With FSM, you can treat, I guess you can treat the urethra, and the sympathetic nerves control the bladder sphincter at the urethra. So maybe the nerves got stretched or something during childbirth. That's possible. So you might be able to treat the nerves. So what I recommend, the rule is always, what tissue is it? What's wrong with it? That's easy. What tissue is it? What's wrong with it? So Google, I love Google. It's really makes your life simpler. Search stress incontinence. That's what you're talking about, stress incontinence. And that's when your bladder's full and you can't hold it quite until you get to the bathroom. And so stress incontinence, what contributes? Sympathetics, pelvic floor muscles, and the bladder sphincter, and sometimes the bladder itself. But those are the things. And it's multifactorial. So Kegel muscles, yeah, you really do have to do Kegels. You can't just think about them. And for goodness sake, if at all possible, avoid the bladder sling that they do, because that's where you get pudendal neuritis, because that sling goes under the bladder, under the urethra. It's ugly, and it's really easy to damage the pudendal nerve during that surgery. So it's one of my least favorite surgeries. So don't do that. Try a more conservative approach. But that's a good question, Lisa. Thank you so much. I'm glad you're here too. Okay, hi Alice. Just diagnosed with calcified tendon in my shoulder. It's called calcific tendonitis. 91, 217, time dependent. Yeah, probably. The advanced in Symposium were amazing. You're very welcome. They were. It just keeps getting better. When you think it can't get better, David Musnick's presentations, both of them, one on long COVID and one on, I think, sleep, were brilliant. Christy Hughes did really well at the Symposium. We had Roger Bellica doing Lyme. We had Becky Blodgett was amazing on sleep. The case reports are great. It was just amazing. Any calcified tendon is calcified because there's constant stress on it. There's constant pull on it. Remember Wolff's Law. If there's constant tension, let's calcify the thing. So you can run 91 and 217. They are time dependent, but the trick is to find out which tendon is calcified and get it to move. Do a motion that gets it to move. Usually calcific tendonitis is the supraspinatus and maybe the infraspinatus and one of the teres, maybe the biceps tendon. And those are tight because of the whole shoulder dysfunction thing that we treat in the supine neck and shoulder practicum. So get somebody to get their fingers in your armpit and get the subscap loose so that you're able to move those muscles. And then the movements that you want are small, no big weights. Don't do that. No big weights, just little movements, just with a little resistance so that the muscle has to move. And you run 91 and 217, yay, but movement, you get it to move. And you're looking at 3 months. And 124 and 77 or 124 and 191, torn and broken in the flat tendons or the round tendons are usually, partial thickness tendon tears are usually what makes the muscles really tight, which sounds really odd, right? They're partial thickness tears and they're calcified. That doesn't make any sense. But because they have partial thickness tears, they're really tight. And once they're really tight, the body calcifies them. So you got to get them to move. And the only way to get them to move is to fix the partial thickness tears. So yes, 91 and 217, great idea. But be sure and check for 124 and 77, torn and broken. Kim calls it repair and heal. But I think of it, what's wrong with it? What's wrong with it is it's partial thickness tears. So torn and broken, 124 and 77 and 191, get the muscle to relax and stop pulling on the bone, and then do the calcification, see where you get. And realistic expectations, you're talking about 2 to 3 months to absorb the things. That would be my guess. You understand that we just guess at this stuff. Okay. Hi, Summer. Welcome home. Thank you. Great event. Yes, it was great to see you. What was the frequency pair for Tarlov cysts? It's not frequency pairs so much as it is, think about what is a Tarlov cyst. Okay. Tarlov cyst is where that picture in the core where it shows the dura, and then the nerve comes out of the dura through that little hole where the dura, if this is a nerve, and the dura has this little cone around the end of the nerve where the nerve leaves the spinal cord. The dura is actually 3 layers, the dura, the pia, and the arachnoid. And the arachnoid is I think the middle one. Always, that part doesn't make sense to me because I always think of the arachnoid should be the closest one because it's the one that absorbs the spinal fluid, okay? But it's the middle one. So you've got the dura wrapped around the nerve, and a Tarlov cyst, my idea about it, is it's fluid that accumulates inside the dura around the nerve ending. So you have this little bulge where the nerve exits the spine. And the only reason that bulge would be there is if you remember, the arachnoid has as its job to absorb spinal fluid and send it back into the main column so it gets back up to the brain where it belongs. If the arachnoid is scarred, it can't absorb spinal fluid. And it's like having hair on the drain. So for me, and I haven't treated that many Tarlov cysts, so we'll see how we do this, how she does. But scarring in the dura, that one's a given. The arachnoid is 474, and that's investigational. I have no proof that it works, but I treated scarring on the dura, and I actually had her rotate to get the nerve to move. Use scarring, that loosens the scar tissue, and then you have to move it. So scarring in the arachnoid, and since a lot of hers were in the thoracic and lumbar spine, we got her low back to rotate and then her trunk to rotate, and it worked. So that was pretty cool. So it's not a frequency, but it's not like there's a pair for Tarlov cysts. You have to think through what tissue is it, what's wrong with it. It has to be scarring in the dura and scarring in the arachnoid. It's like having hair in the drain, and the arachnoid can't absorb the fluid that it should absorb when the dura is wrapped around that little nerve root where it exits the spine. So you get something called, they call it a Tarlov cyst because some guy named Tarlov said, hey, there's a cyst there. I get to name it. So he names it after himself. So you do scarring on the dura and the arachnoid, and then rotate the patient or side bend the patient so that the nerve gets to move while you're treating scarring in the arachnoid and scarring on the nerve. That was the other piece of that. Summer, how long does it take to schedule you with me and Troutdale? It really depends. Joseph informed me yesterday that he just booked a patient into October. I have holes in June, I have holes in July. My challenge is I teach, so when there's a core, we're closed. And I just told Joseph that I'm taking a week and going to Christie's Retreat Center in Hilo in Hawaii in August. So I'm going to be gone for a week in August. Then we go for 2 weeks to Rome. And then in November, we go to Costa Rica. It's a while, May, June, like June, July, we have some holes. And then Sandra's schedule is more open than mine. And she's really good at what she does. People want to see me because I wrote a book. but Sandra's really good at what she does. So if you need to be seen before you can see me, see Sandra. Debbie, a full advanced, how exciting. It really is, except it means that I've got to spend several Saturdays and Sundays rewriting the advanced, which will be very good for me. What was said at the conference is that 319 and 322 and 20. Oh, goody. Thank you, Catherine. So it is the 19th to 22nd. This year, it was cold and rainy in the first part of March. So I moved it after daylight savings time changes. And I think you're correct at 319 and 26. Now you got me, March. Yep, the advanced is, all right, one is, the core is going to be the 11th through the 15th, then 3 days for sports, and then the advanced is the 19th through the 22nd. There we go. We'll get it on video, so you'll have it to watch. It'll be fun. You'll like it. 19th through the 22nd. And that, yeah, that'll go. That'll be fun. Thank you, Catherine. Now you got me to put it in my phone. That's a good start. Lisa, how can FSM help with emotional regulation and focus? Emotional regulation, people are talking about using the 970s for specific emotions. And I have gotten to the point where I use 40 and 89 first. I just do. And focus, when your sympathetics, I think the technical medical term is jacked up. When the sympathetics are jacked up, your focus shifts constantly looking for threat. That's just how we keep you alive. That's what the brain's job is. And concussion in vagus, and I increase the time that is spent on 40 and 89 to maybe 30 minutes, and then increase secretions in the vagus for another 20 minutes. So you can run an hour on concussion and vagus just doing that. Mental focus, if you turn down the limbic system, you turn down anxiety, fear, threat, perception, all of that stuff. If you turn that down, then I guess you could do the basics and increase secretions in the cortex and get that to balance. There's a frequency for the prefrontal cortex, but it's still investigational. I have no objective evidence that it actually works, but the prefrontal cortex is involved in mental focus. But if you turn up the cortex and get the midbrain to just take a nap, and you increase secretions in the vagus, decreases inflammation, increases brain-derived nerve growth factor, increases oxygen and nitric oxide to the brain, increases something that starts with an S that's really good for the brain, increases serotonin, and increases norepinephrine, which norepinephrine is a stress hormone, but in the cortex, it increases focus, right? Norepinephrine, if you think about it as a stress hormone, it's focus. Tiger, snake, focus. That. So that's what I do. I don't use the 970s a lot anymore. I probably should. I use them occasionally. If I had treated this patient for just fear, 970 and 27, terror, and 23 over concern, I don't think it would have worked. She was centrally sensitized and spinal cord sensitized. And when I say, Lisa, when I say turn it down or have it take a nap, I am referring to 40. So if you think about the vagal tone protocol, so you have concussion, vagal tone is 94 and 94. You've already done that in concussion. Then you do 40 and 94. quiet the medulla, because that's where the vagal nuclei are, both of them. And then quiet the midbrain, because you want to quiet down the limbic system, because it perceives threat, maybe when there isn't any. And then bring up the vagus, 94, 81, 49, all with 109. And if somebody has brain fog from long COVID, then you want to run the viral frequencies, 38, 41, 44, 56, 160, 189, with the vagus and the capillaries and the brain, because the vagus is turned down by infection, viruses, stress, and trauma. That makes sense. Okay, hold on. Cleanan? Poneth? Okay, hold that thought. I have Lisa over here. Amygdala really helps my clients with so many aspects of emotional problems. Absolutely. 40 and 89 is your friend. And one of the presentations at the symposium was about a patient, a practitioner actually, who ran 40 and 89, quiet down the thalamus for 18 hours, 6 hours a day for 3 days. And at the end of the third day, she completely came apart. Body pain went up. Her brain stopped working. She lost her house. She lost her job. She moved into assisted living. She was a mess. That's what Patrick Wood lectured about. He is my psychoneuroimmunology geeky friend. He's an MD. We lectured together on the fibromyalgia circuit 20 years ago and formed a bond. And so if you turn the limbic system down too far, and I would say that 40 and 89 for 18 hours is too far, you take it completely out of the circuit, and it serves a function to connect or regulate information that goes to the cortex. Everything goes through the limbic system. And if you take it completely out of the loop, then you end up with thalamic pain. It's like having a thalamic stroke, and your brain doesn't work so well. So 18 hours is too long. 30 minutes is fine for the average jacked up patient. Okay, amygdala, absolutely. And I use 89, the George's experimental frequency for the limbic system, the deep limbic system, and the amygdala never does much for me. I'm old-fashioned. I just use 89. Klein, Kleinnne. Not sure how to pronounce that. I have a 56-year-old patient who was poisoned with rat poison by his stepson. Okay, that's bad. Has stage 3 renal failure. Yeah, rat poison will do that. Type 2 diabetes, he's hypertension, in remission from prostate cancer. I'm hoping the stepson is someplace else and has had therapy. I've seen him once, treated him with chemo detox, worked a little bit on his kidneys. Wow, that's messed up. Stage 3 renal failure. The rat poison I'm familiar with is warfarin, and it is an anticoagulant. It makes you bleed, and it affects the blood vessels, and the kidneys are mostly capillaries. If you've ever been to Body Worlds, the exhibit that shows the kidneys, where all of the kidney is removed except for the capillaries. And it's like lace. It is magnificent. So the kidney is all these little teeny capillaries. It's like they're the size of silk threads, all interwoven. And then you put the kidney tubules and stuff next to the little blood supply. So what kind of rat poison? So probably 57, 900, 920 in case it's just toxicity. But I treat it for hemorrhage, maybe 18 and 162. So the kidney is primarily capillaries, 162. And I tried that. The question is the renal failure caused by the type 2 diabetes, what's his A1C, how bad is his diabetes, is he insulin dependent? Because diabetics, the diabetes clogs up the blood supply and gives them macular degeneration, peripheral neuropathies, and kidney failure. They go into dialysis. Yeah. Type 2 diabetes is not fun. Hypertension, that makes me wonder, does he have sleep apnea? So I do a sleep study on him, number one. Hypertension, if you listen to Mark Houston, hypertension is is a response to vascular damage. So I'm not entirely sure of the mechanism, but I've heard him say that. And if you listen to Mark Houston long enough, you learn to believe whatever he says. So if he's hypertensive and on medication and not responding to medication, test him for sleep apnea. Oh dear. Okay. So I forgot to mention that a week ago, the blood vessels in his left eye burst and he lost his vision. So he has wet macular degeneration. So a lot of this has to do with the type 2 diabetes. So you get his blood sugar and pretty much put the fear of God into him. No, carbohydrates are not your friend. Yes, you need to ask your MD for a blood sugar meter. You need to ask your MD for insulin. Like your hemoglobin A1C needs to be 6 or 5.7. That's it. And for some reason, once this guy's young, 56, this is somebody who's 70. The strangest thing happens in medicine. Somebody's 70 years old and they have type 2 diabetes. They don't have a constant blood sugar, one of those little things, patches you put on your arm, and then you get a constant blood sugar on your phone from your patch that communicates with Bluetooth. I don't want electricity. Get over it. The blood sugar is a lot more dangerous than any Wi-Fi you've ever been around. And so get an MD, get your doctor to treat you properly for diabetes and have him get a sleep test, sleep study. You're going to have to treat him more than a little bit on his kidneys. What I'd suggest is insulin resistance, vascular health. So we have a protocol in the custom care called vascular health that treats the arteries, the capillaries, and the veins for torn and broken inflammation and vitality. And you just run it neck to feet. I run it every night. Really important in people that have had either COVID vaccines or COVID itself or both. He's got wet macular degeneration, so he's pretty far along on this path. I'd find out what his hemoglobin A1C is and find out if he snores. And I'm glad his prostate's better. Chemo detox is the least of his problems. Work a lot on his kidneys, work a lot on his blood vessels, and do the rest of what you need to do to be a good healthcare provider. That I found out yesterday when I talked to this patient. I found out that I'm really serious about my job when it comes to patients. My job is to fix you, whatever that takes. If it takes a sleep study, we'll do a sleep study. If it takes giving you a note to send to your doctor and tell the doctor to give you a sleep study and proper antihypertensive medication and get your damn blood sugar down, if that's what it takes, do that. We don't fix everybody with FSM. We fix people by actually caring about whether or not they get better. Nobody else does that, it seems. End of I'm really ranting a little bit today. Hope you don't mind. I know you don't touch the eyes. Wet macular degeneration is no. Yeah, you're right, Lisa. Sorry. Your eyesight is blurry because of age. That's just how it is. You start out with reading glasses from the pharmacy, from Walgreens or CVS or whatever, and you get them until you can read. And that's as long as both eyes are the same. And if both eyes are not the same, like mine, you spend the money and you get prescription glasses. And just if your car needed brakes, you put brakes. If your car needed a transmission, you spend the money and get a transmission. Just because it's your body doesn't mean you don't want to spend the money on it. What's more important, your car or your body? Your body's more important thing. And yeah, your vision is blurry because of your age. That's just the way it goes. My dad did exercises from the time he was 30 till the time he was 92, and he never did wear glasses. Couldn't see for beans the last couple of years of his life, but he didn't care. He could see distance. He just couldn't read very well, but he did his exercises. Like we're talking 2 or 3 times a day. It's just easier to wear reading glasses. And look at these. You can hardly tell that I have them, and I wear them all the time. Yeah, sorry. DNA. I'm not sure who that is. Ramsay-Hunt syndrome. It's not a version of shingles. It's like post-traumatic neuralgia. Not able to blink in the left eye, left facial paralysis. So he had shingles in the facial nerve, hearing loss. Ooh, ick. And it wasn't just the facial nerve. It was also, so the facial nerve is 7, and the audiocochlear nerve, so the vestibular cochlear nerve is the one that's in charge of hearing and balance. And the viruses have the shingles protocols, and the shingles protocol has problems with the cranial nerves because you can't get at the nerve cell body, which is inside the brain. So you're dealing with post-herpetic neuralgia in a cranial nerve. And if you pay attention to the core seminar, she would pay attention to the core seminar. It says that it's not effective for cranial nerves. You can try it. You run the frequencies for shingles, and then if the 7th and 8th cranial nerve come out of the pons. So you treat the pons for 160 malignant virus, and then maybe in trauma, torn and broken, and you'd put it around the neck and over the ear and the face. So red and green here and black and yellow on the face and the ear. And see, cranial nerves are tough. And they both come out of the pons, which is 454. I know that frequency is correct. We do have frequencies now and it'll be in the buddy for the facial nerve and the vestibular cochlear nerve. Facial paralysis is the facial nerve, 7, and hearing is 8. So I wouldn't be overly hopeful, but it's worth a try. It's not like anything else that's going to work. Summer, okay, wait, we're going to go over to this side. Denise, you'd put the towels where all the brain work, back of the neck, abdomen or upper chest. Yes, Ramsay-Hunt includes the vagus and the trigeminal. Ramsay-Hunt can be any number of nerves, but yeah, vagus and the trigeminal. The vagus is in the medulla. Trigeminal nerve comes out of the pons, so it's a little bit different. That's 5. So the vagus, so 10, 11, and 12, and maybe 9 come out of the medulla, and age 7, 6, 5, 4, 3 come out of the pons. So I'd treat the pons, and then when we get the frequencies for the vagus and the trigeminal nerve, you can go with that. Summer, I have a client on her way here from the dentist. She would like to detox anesthesia. Okay. Anesthesia, mouth tissue rather than full. Oh yeah, definitely use. And it's not just the mouth. It's they anesthetize the nerves in the mouth. So you're going to use 19 and 396. 19 and the sensory to the face is 7. Motor to the face is 5, not 7. Yes, 5, 7, facial nerve. Is there a custom care program for wisdom teeth removal? There's a custom care program for, yes, I know it's 4 o'clock, Kevin. It's like exactly 4 o'clock. I have 30 more seconds. Is there a custom care program for wisdom teeth removal? It's post-op jaw. And you run it while the patient, you start post-op jaw day 1, while the patient's still in the chair or when they get out to the car. And you put the sticky pads on the jaw here, red on the right, green down here on the neck, green on the left, yellow here, post-op jaw. And it's 4 o'clock. I made it without Kim and everything, right? I really miss Kim. It's more fun when she's here because then I have somebody else to bounce it off of. But I had a really good time with you guys. Thank you very much for everything. Next week, I think Kim will be here and we'll be on a plane on our way to Austin to the Forum for Integrative Medicine. It's going to be a really good meeting. So do good things, save lives, change the world, our basic mission. I love you all, and we'll talk to you in 2 weeks. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.